Hi, how are you? My name is Christian. I'm going to be your provider for today. How are you doing today?
I'm doing well, thank you.
Good. What's your name?
Raquel St. Just.
Good. So first of all, we're going to be doing an assessment of the head, ears, eyes, nose, throat, neck, cardiovascular, and respiratory. Okay. And to start the assessment, just visually, the patient appears to be posture is erect. She appears well groomed, clean. Nothing out of the ordinary for now. So we're going to start with the head. Okay, we're going to do an inspection of the head. So you ask permission to the patient. I'm going to be checking your scalp. We're going to be just checking for any lesions, any masses, anything that's abnormal. We're going to check between the scalp for any possible infestations. So it's okay if I just touch your head. So you're basically going to move around all throughout the scalp. You're going to palpate. Okay, you're going to see if there's any masses or anything like that that are there. That should not be there. Any tenderness, any pain, or anything like that?
No.
Good. Okay. So we're going to check cranial nerve 5, which is the trigeminal nerve, and cranial 7, which is the facial nerve. Okay, so I'm just going to ask you to bite down for me real quick.
Okay.
Okay. You're going to check over here, the temporal, and the masseter right here, so it's to be intact. Can you open your mouth? Good. So she's able to open her mouth against resistance. Okay, so we can say that cranial number 5 is intact. And for your facial nerve, can you close your eyes, please? Can you frown for me? Okay, can you blow up your cheeks? And can you smile? Okay, so cranial nerve number 7 seems to be intact as well. Okay, so next we're going to move on to the eyes. We're going to begin with the vision. We're going to check distant vision first. Okay, and for that we're going to use the Snellen chart. Snellen chart. We're going to ask you to stand about 20 feet away from the chart, and we're going to ask the patient to read the lowest line that they can possibly read, covering one eye, the left, and then the right, and then uncover both of them, and to see where they are. Okay, and if the patient wears glasses, you will leave the glasses on. So we're going to start with the cover in the right eye. Okay, and again we're 20 feet apart. So if you could just read the lowest line, please.
LTFPH.
Good. Okay, can you uncover the other and then cover the other eye?
LTFPH.
Okay, and just remove that and then just let your eyes adjust and you read both lines, please.
LTFPH.
Good. So this patient is reading at a 20/20 vision here, which means that at 20 feet away, she can read what a person with good vision can read at 20 feet. In a scenario where it was 20/30, let's just say, that means that she can read at 20 feet what a person with good vision can read at 30 feet. Okay. So for the purpose of this is the distant vision Snellen chart. Okay. We're going to move to the Rosenbaum. Rosenbaum chart is used for near vision. It's usually a chart that's about basically the same concept, but 12 to 14 inches away, and you would ask the patient to read, all the letters that they can read. Okay. So for peripheral vision, we're going to do a confrontational test. Okay. So for that, we're going to check 4 quadrants, okay, which is the medial, lateral, inferior, and posterior, okay? And then what we're going to do is we're going to check to see, so I'm going to ask you to stare at my nose, okay? And we are going to cover one eye. I'm going to cover the same eye, and I need you to tell me what number I'm pointing out with my fingers without looking at my hand, just looking at me. You ready? Okay, so if you could just hold that up for me. Okay. Okay, and we're going to go. Let me know if you see a finger.
1, 2, 3.
Okay.
2.
Okay, good. And we're going to repeat the same on the other side. If you could just uncover that. Okay.
1, 1, 2, 3.
Good. Okay. So this is how we're going to check the, thank you, you can put that down, the peripheral vision, okay? Next, we're going to do the Resp test, which is corneal light reflex, okay? What we're going to do is use a pen light, and for that is basically the Resp test is checking for alignment, okay, of the eyes. So we're going to shine this light into the eyes, and we're going to look for the reflection, make sure that it should be reflecting right about the same angle, okay? So I'm just going to, and we'll dim the light actually for that, okay? And I'm just going to stare at the light for me real quick. Okay, and again, basically we're looking for the reflection. Okay, so we're checking for alignment of the eyes and everything of the iris, and everything seems to the pupils. Everything seems to be okay. Okay. Next, we're gonna do put the lights back on. We're gonna do the cover and uncover test. It's also gonna check for peripheral. Okay. So we're just gonna ask you, and we're gonna check for strabismus, which is the swaying of the eye from midline. Okay, so we're just gonna cover this, okay, and we're gonna uncover. Okay, and we're gonna do it again with the other eye. Okay, good. So when we remove the card, the eye seems to be in line. It doesn't deviate, so we can rule out any strabismus. All right, that is for the cover and uncover test. Okay, now we're gonna do cranial nerves 3, 4, and 6, which is the oculomotor. Okay, we're going to do oculomotor. We're going to do the trigeminal, and we're gonna do the abducens, which is cranial nerve number 6. Okay, and we're gonna do the 6 cardinal fields of gaze. Okay, and what I'm gonna do is, without using the light, I'm just gonna ask you to follow, and we're gonna check basically lateral, up, down, medial, left, and right. Okay, and we're gonna check for any deviation. Okay, so just follow this with your eyes, not with your head, please. Okay. And then we're gonna go left, and we're gonna go right. Good. So she's able to follow this with no problem without moving her eyes. Okay, so we can basically rule out that her extraocular muscles are intact as well. Next, we're gonna move on to Perla. Perla, we're gonna check for pupil to see if they're equal, round, and reactive to light and accommodation. Okay, so we're gonna turn the lights off real quick to dim the lights. Okay. And what I'm going to do is just put the light on the side, and while you're expecting, we're going to check for any anisocoria, which is the difference in pupil size. 3 to 5 is what's considered normal. So if they're equal, we'll be able to tell. And when we shine the light, they should go down. For someone who's at about maybe a 3, they should go down to about a 1, more or less. Okay, so just going to come in here. Just stare straight ahead, please. Okay, and we're going to do this side as well. Okay, good. So by shining the light, the eyes, the pupils constrict as they should. When you look far away, they should dilate. Okay. Now fundoscopic test, all right, which is we're gonna check the back of the eye to check for the blood vessels, check for the retina, the macula, just to see if anything looks out of the ordinary. And for this, we're gonna check the patient's right eye using my right eye and my right hand, and then we're gonna use the other way around. Okay. So I'm just gonna ask you to kind of just stare at a distant object, okay? And I'm gonna come here. Okay, and there. And we're gonna go on this side as well, okay? Just keep staring straight. Good, okay. So again, we're checking the blood vessels, we're checking for any abnormalities there, everything seems to be okay. Next, we're gonna move on to the ears. Okay, any questions? Good. So in the ear inspection, we're gonna do an inspection. And what we're going to do is we're gonna do a quick palpation, make sure for any tenderness. We're gonna check the tragus, okay? Any tenderness here?
No.
Any pain on the pulling down on the pinna?
No.
Okay. So everything seems to be symmetrical. There's no drainage, no discharge, anything like that, no nodules. So we're gonna use the otoscope, okay, with the light. We're gonna be checking the tympanic membrane. We're gonna be looking for color. The color should be grayish and translucent. So what we're gonna do for an adult, we're gonna pull the pinna up and back. We're just gonna take a quick look and see what's going on there. Okay, so you could just kind of turn this way for me a little bit, and I'm gonna pull up and back. Okay, so it looks good. Is the grayish translucent color that should be there, and we're gonna do the same thing on this side as well. So we're gonna do up and back. Okay, so nothing abnormal there on this assessment. Next, we're going to do the Weber test. Thank you. The Weber test is going to check for conduction, okay, for hearing loss actually. So what we're going to do is we're going to use a 512 hertz tuning fork. I'm going to strike it. I'm going to place it basically in the middle, and you're going to tell me if you hear it louder on the left side or the right side. For normal results, it should be equal on both sides. Okay, so just gonna. Do you hear it equally?
Yes.
Equal. Okay. So Patient states that they hear it equally, so then this test is normal. Then we're going to check for sensorineural and conductive hearing, okay? And with this, we're going to do a rin test. With the rin test, we're going to use the same fork. We're going to place it on the mastoid process right here, which is the bone behind the ear. The patient should be able to hear it there. And then we're going to place it next to the ear. They should be hearing it longer there, which means because the right results is air conduction should be longer than bone conduction, okay? So we're going to do this side, okay? We're going to strike it. Let me know when you can't hear it.
Can't hear it anymore.
How about now?
Still hear it.
Okay, good. And we'll do the same thing on the other side. Let me know when you can't hear it.
Can't hear it.
How about now?
Still hear it.
Good. Okay. Good. So there's no hearing loss. It seems to be intact. Okay. Next, we're gonna do the whisper test. I'm gonna cover your right ear and left ear, and I'm gonna whisper something. I just need you to repeat what it is when I tell it to you. Okay.
Okay.
I'm just gonna go. White dog.
White dog.
Good. I'm gonna do the other side.
Blue banana.
Very good. So blue banana. So she was able to repeat everything with no problem. So we can rule out any hearing deficiencies or loss, and it's safe to say that the patient is okay with her hearing. Next, we're gonna move on to the nose. Okay, we're gonna inspect. Okay, so I'm just gonna kind of palpate real quick, check for any tenderness, anything like that. It seems symmetrical. There's no abnormal, no drainage, anything like that. Any tenderness or pain?
No.
Anything abnormal? Good. Okay, so we're gonna check for deviated septum. All right, so we're gonna put the light in here, and let me see if you could just look up for me, please. I'm gonna look up here. Okay, so the air seems to be fine. Can you cover one nostril and breathe in? Okay, and then do the other one. Good. Any discomfort?
No.
Okay, so we're gonna check the airway seems pain, no discomfort there. Okay, we're also gonna check the sinuses. So I'm gonna just check above the eye, which is the frontal sinuses. Any tenderness, anything?
No.
Okay, then we're gonna move down to the maxillary. Okay, the maxillary is above the cheeks. Any discomfort there?
No.
Okay, good. Okay, and then we're gonna check the. I need you to close your eyes for me, and we're gonna check cranial nerve number 1, which is the olfactory. Okay, so I'm just gonna put something on your nose. I need you to tell me what it is that you were smelling. Okay, please close your eyes and tell me what you smell.
Garlic.
Yes. Okay, so it is garlic. So the patient, you can open your eyes. Thank you. The patient's sense of smell is intact as well. Okay. All right. And then now we're gonna move to the throat and mouth. Okay. So I'm gonna wear some gloves. What we're gonna do here is we're gonna check for any the mucosa inside. Okay, it should be moist. Inside of the mouth should be pink. We're gonna inspect the tongue as well. It should be pink, not red, as you would see somebody with like pernicious anemia or something like that. Okay. We're gonna check the gums. We're gonna check for any loose, broken, missing teeth, any dentures, anything like that. Okay. So we do hand hygiene, okay, before we do this, and we always let the patient know what we're going to be doing. Okay. Okay. And I'm going to use my pen line again, and I'm just going to ask you to look up for me, please, and open your mouth. Okay, so you're going to review and check for the hard palate, soft palate, and you're going to just let the patient know you're going to go in her mouth a little bit just to check, okay? Any tenderness?
No.
Okay. No lesions, anything like that. All the mouth seems to be okay. The tongue color is appropriate. There's no halitosis or anything like that noted. So the patient's mouth seems to be, intact. We're going to check cranial nerve number 12. I'm just going to ask you to take your tongue out and move it left and right. Left and right, good. So we can rule out cranial nerve, which is the hypoglossal, is intact, okay? And we are going to check the cranial nerve number 9 and 10, which is the glossopharyngeal and the vagus cranial nerve. I am just going to put something to check the posterior of the tongue and just to check the gag reflex, okay?
Okay.
Okay, so just open up for me, please. Okay, just gonna. Okay, so there's a gag reflex that seems to be intact, and I will ask you to open up again and just say ah for me when you ah.
Ah.
And you're gonna check for the uvula. The uvula is the tonsils in the uvula goes up when the patient says ah. Can you say ah?
Ah.
Good. Okay, so that seems to be intact as well. Okay, so that is that. Any questions?
No question.
Okay, now for the neck. Okay, we're gonna move on to the neck. You're doing great, by the way. And for the neck, we're going to do an inspection. Okay, just really quick. We're gonna check for symmetry. Okay, any nodules, any masses, any abnormal size, such as something you would see somebody with goiter, you know, enlarged. But in this case, it seems to be okay. So what we're gonna do is we're going to palpate the carotid pulses. I'm gonna go from behind and just kind of check, okay? And you're gonna do them simultaneously, not at the same time. You don't need the patient to be passing out or anything like that, okay? And then we're gonna auscultate. And with the auscultation, we're gonna use the bell of the stethoscope because we wanna listen for the lower pitch sounds, okay? So I'm just gonna go behind you, okay?
Okay.
And we're gonna check here, okay? And just move your neck this way for a little bit. And I'm just gonna palpate, and then with one. Good. Okay, and just look the other way for me real quick. Good. Okay. And then now we're going to check. We're going to again the thyroid. Okay. You want to feel? Just look up for me, please. You're going to check the patient's thyroid here. Okay. You're checking for masses, anything like that. Nothing abnormal upon appearance. And again, we're going to use the stethoscope and listen for some sounds. Okay. So we're going to go above the carotid. Okay. And I will ask you to take it to hold your breath for a quick second.
Okay.
Okay. And if we could do it on the other side as well, and hold your breath. Okay. You're listening for some bruit or anything like that that's abnormal. In this case, everything sounds good. And so now I'm going to auscultate on the over the thyroid. Okay. So no abnormal sounds, and I also checked over the isthmus, which is right over the tracheal area. Any difficulty swallowing or anything like that?
No.
Okay, good. So now we're gonna move on to the anterior chest. Okay, so looking at the patient. Okay, we're looking at posture, which we did say before. The patient is erect. Patient has no apparent chest expansion as abnormal, such as barrel chest or anything like that. So such as patients with COPD. But in this case, she seems to be normal. Any difficulty breathing?
No.
Okay. Her breathing seems to be intact. Okay. Just looking at the pattern, it's non-labored. It's within normal limits. There's no apnea. There's no tachypnea, anything like that. So that's fine. All right. So we set the shape, respiration rate. So now we're gonna palpate. Okay. We're just gonna use the finger of our tips, and we're just kind of gonna go. And if it's okay with you, and you ask the patient permission, just gonna kind of touch to see if there's any tenderness or anything like that. This is for the anterior chest. Let me know if you feel anything.
No.
Okay, good. And then we're going to auscultate. And for auscultation, we're going to use the diaphragm here. And we're going to start from above the clavicular, and we're going to basically move side to side, left, right, all the way down. Okay? So just take some deep breath for me, please. Okay. Okay, and just kind of lift your arm up a little bit. So we're going to check the side of the axillary here for the right lobe, middle lobe. Okay, and one last breath. Good. Okay, so no adventitious sounds auscultated on this assessment. Okay, so now we're going to move on to the posterior of the chest. If you can just turn around this way, so you can kind of see. So what we're going to do is we're going to do an inspection of the chest. Same thing. Okay, I'm just going to move this over here. Looking at symmetry, looking at position, the patient back. There's no apparent lordosis, kyphosis, scoliosis, anything like that. Everything seems to be symmetrical and in line as it should be. Okay, so so that's the inspection. We're gonna palpate the same way we did the front. Okay, so I'm just gonna kind of go down and just check to see if there's any tenderness, any pain. Let me know. Okay, and you're gonna go around, basically trying to stay midline to go around the scapula. Okay.
Okay.
Any pain, any discomfort.
No.
Okay. All right. So that seems to be intact. So we're going to do a percussion of the chest, basically using the fingers, and just check all again, starting left, right, up, and down. Okay. So we're gonna do here, and we're gonna do. And we want to do it simultaneously so you can listen to see if there are any differences. You don't want to go, up and then down, left, right. You want to kind of be symmetrical as you go down, so you can do a nice even comparison. Okay. You hear the resonance in the domes on here. Okay, so next we're going to auscultate. Same thing. We're going to start from the top, okay, above, and we're going to work our way down. We're going to check for any wheezing, any crackles, anything like that. All right, so we're going to start from the top again. I'm sorry. So just take a couple of deep breaths for me, okay? Okay. Again. Okay. 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 And the lower. Good. Again, keeping in mind we're going around the scapula, so because otherwise you're going to be listening over bone. Okay. Next, we're going to do tactile frequencies. Okay. So what I'm just going to do is I'm just going to feel the vibration. Okay. On words 99 is what I'm going to ask you to repeat just consecutively as I go down and feel. Okay.
Okay.
We're going to start from the top, from behind. Okay. You ready?
Yes.
Okay. Just repeat 99.
99.
Okay. Again.
99.
Okay.
99.
Okay.
99.
Okay.
99.
Okay.
99.
Okay.
99.
Very good. Okay, so everything seems to be, the vibration seems to be normal all across. Okay, so next you can actually come around, please, and back this way. Okay, we're gonna move on to the heart. With heart, we're gonna be listening to some heart sounds. Okay, so just looking at the chest, we're gonna be doing with both the bell and the diaphragm of the stethoscope, because you want to listen for murmurs or any abnormal sounds. Okay, so we got the sternal notch right here. Okay, you go in between, you go down to the angle of Louis. And when you're at the angle of Louis, you're going to go down to the second intercostal space to the right of the patient, okay? And that is going to be the aortic valve, okay? So 2 down to the right. I'm gonna listen over here. Then we're gonna move over second intercostal space to the left of the angle of Louis. That's gonna be your pulmonic. Okay, third intercostal space, you're going to do the Herbst point. You're going to go down to the fifth intercostal space. Okay, and this is going to be the tricuspid valve. And on the same fifth intercostal space, you're going to move down mid-clavicular to the same fifth that you're in. And this is you're going to check for the mitral valve, which is the point of maximal impulse. This is where you'll be able to hear the sound the loudest. Okay, so no abnormal sounds. S1, S2 is there. You would be listening to for S3 is 4 sounds, and then we're gonna repeat the same thing with the bell. Okay, so we're gonna go down second to the right with the bell. Okay. Pulmonic down to Herbst point. Down to the tricuspid, the fifth. And fifth, mid-clavicular all the way down, the mitral. Okay, everything seems to be normal. Okay, good. Any questions?
No.
Good. So we're going to check for JVD, jugular vein distension. I'm just going to look up and we're going to ask the patient to look left or right. You're going to check over here to see if there's any distension. There shouldn't be any because that would be an abnormal finding. But in this case, if you could just look here. Good. So no distension noted on the side of the neck. Okay. So we're going to check now for this next part. I'm going to ask the patient to lay down really quick, and we're going to be checking for the some of the basic arteries over here in the abdominal. I'm going to just ask you, okay, if you could just lay down for me. And in this case, okay, you're gonna go right underneath the diaphragm, okay, and we're gonna check for the aortic valve. We're going to palpate, we're gonna check, okay, we're gonna press down, and you should be able to kind of feel where exactly it is. So we're gonna find, okay, we're gonna press down. Okay, you should be able to feel the pulse on there as well, okay. Then right by the aortic is the renal, then you move down to the iliac, and you're gonna get to check the femoral. Okay, so for this also, again, we're gonna auscultate it as well. All right, so we're gonna again the aortic. This is right below the diaphragm, above the umbilical. Okay, and we're gonna check the renal to the side of that. Then we're gonna move down to the iliac. And we're going to check the femoral arteries as well as palpation. Good. So I'm just going to check the femoral arteries, okay? Good. Okay. You can sit back up. Okay. There are no abnormal findings here. You always help your patient up. Okay. We're going to check capillary refill. Okay. So we're going to press down on the fingernails, and it should return back to normal color within 3 seconds or less. That's a normal finding. So we're just going to do a couple of them. Okay. We're just going to squeeze. Okay. 3 seconds. 2 seconds. You don't need to do all of them. Just do some, and you can document that capillary refill is intact at this point. Okay. And then we're going to do your pulses. All right. Your pulses. We're going to check your brachial. Okay, so we're gonna just ask the patient to extend their arm. We're gonna check the brachial pulse right here in the antecubital space. Okay, and then we're gonna check the brachial pulse, which is right by the thumb. And then we have the ulnar, which is on the other side. Okay, then you have if you can just lay down again, I'm sorry, the popliteal, which is in back of the knees, okay? You may want to ask the patient to bend their arms, their legs a little bit, so you want to kind of squeeze in there. Okay, and that's pounding. Good. Popliteals are good. Okay, and lastly, I'm just going to ask your feet over here. You're going to check dorsalis pedis right here, which is right above the foot. And you'll do that on both sides, okay? And then lastly, you're going to check the posterior tibial, which is basically on the side of the ankle, if you will, right here. Okay, and you'll do that for both sides. Okay, help your patient up. Do you have any questions?
No.
Okay, this concludes our examination. Okay, thank you very much for your time. All right.